Hello and thanks for joining me again today. Today we'll be discussing hemodialysis access and also complications associated with hemodialysis access. Also, for further readings on this topic, you can pick up my book on Amazon, Vascular Technology Made Simple. This book is also available on Kindle. So as stated earlier, we will identify types of arteriovenous fistula, identify common loop grafts, and also complications associated with hemodialysis access. So sometimes you would hear the word hemodialysis access or also vascular access. And this type of procedure is performed on patients who are with renal failure. So patients whose kidneys are no longer functioning are likely to be on dialysis. And there are three types of hemodialysis access. You have the arteriovenous fistula, which is performed by joining an artery and a vein in the arm. You have the dialysis graft, which is performed using a graft to join an artery and a vein. And you have the catheter, which is a tube placement in a large vein in the neck. So the three most common arteriovenous fistula, you have the brachial, which is the connection between the radial artery and the cephalic vein at the wrist. So you have the seminal. The brachial seminal is also known as the seminal, which is right at the patient's radial artery at the wrist. The cephalic vein is connected to the artery, or the artery is connected to the cephalic vein. Then you have your brachiocephalic, which is the connection between the brachial artery and the cephalic vein at the antecubital fossa. So usually the first choice would be a radiocephalic. If the veins in the forearm are small, then the doctor would move up to a brachiocephalic dialysis access. When the brachiocephalic is small, at that time the doctor would move into performing a brachiobasilic vein transposition. And the brachiobasilic vein transposition is the connection between the brachial artery and the basilic vein. Then the fistula is further transposed superficially to provide adequate access for dialysis. So once the first part of surgery is done with a patient with brachiobasilic, then the fistula is further transposed to make it a lot superficial for access during dialysis. And this has to be done because your basilic vein, don't forget, is in the inner part of your arm and in the medial aspect of your arm. And for the dialysis nurses to have access to it, the basilic vein has to be moved over to the top part of the arm to make access for dialysis a lot smoother. The arteriovenous fistula 1 is the first choice for hemodialysis patients. Why? Because it lasts longer, and 2 is fewer complications with AVF, arteriovenous fistula, where the vein of the patient and artery is used for access. It makes again, you're using the patient's vessel, so automatically lasts longer, and 2, there are less complications from this type of access. When studying a bypass graft, AVF, and stents, spectral and duplex images should include inflow vessels, proximal, mid, and distal segments, inflow and outflow anastomosis sites. When interrogating the dialysis / fistula images, observe for, you want to make sure they don't have perigraft fluid, which can be indicative of an infection. You want to make sure they don't have an aneurysm, an hematoma, stenosis. So again, when duplexing the fistula, you want to make sure that so far the 4 listed are not seen. If seen, they need to be addressed usually right away. When studying AVF, you want to pay attention to the anastomosis and outflow vein, also for possible stenosis. You want to obtain volume flow when studying the AVF. You want to obtain it at the proximal, mid, and at the distal segment of the AVF fistula. When studying an AVF, you want to, of course, document volume flow. And below here are what a normal volume flow should be in your fistula. Volume flow within dialysis access helps predict patency and successful use of access. Volume flow of less than 600 ml per minute is considered low. 600 ml per minute to 800 ml per minute is satisfactory, and anything greater than 800 ml per minute is considered high. Please, you want to follow your department's protocol. Every department has a different criteria for volume flow. Also, when documenting volume flow, you don't want to document your volume flow at the anastomosis site and at the stenotic site, because this will give you a falsely elevated volume flow. So you want to keep in mind that you want to obtain your volume flow where there isn't a stenosis and where the flow is where you have a smooth flow, laminar flow, I'll say, when documenting your volume flow. The three most common AV fistula are imaged below. The first image is just a normal anatomy of the upper extremity. The second image, which is the brachiocephalic shunt, it says, which is the brachiocephalic venous fistula. You can see the cephalic there, and the brachial artery. You can see the anastomosis at that site. That's where the connection would take place for a brachiocephalic fistula. The third image is the radiocephalic fistula, and you can see at the wrist there, your radial artery and your cephalic vein at the wrist would be connected right at the wrist, and that is known as your radiocephalic fistula. So these are the three, the top two, I must say, the top two most common AVF you would see as seen in this image here. Here you have an image of the radiocephalic AVF fistula. You can see the anastomosis site. You can see a cephalic vein, and right at the middle of this image, you can see the anastomosis site of the cephalic vein to the radial artery. In the image in the center, you can see it with color flow, with color Doppler. You can see the turbulence in the fistula. Of course, this is because you have connected a vein to an artery, and usually flow within a fistula is quite turbulent. In the third image there, you can see the waveforms, elevated velocity, peak systolic and end diastolic velocity. You can see the volume flow in this image is 1,699 ml per minute. In this image here, the volume flow is elevated in this image because it is documented close to the anastomosis site. So the volume flow here is 1699 ml per minute, and that's again because the volume flow is being obtained at the anastomosis site. You want to try to obtain a volume flow a little bit distal to the anastomosis site, definitely at the mid segment of the fistula as well. Now, the four most common dialysis grafts, you have the forearm loop graft, which is a connection between the brachial artery to the antecubital vein. You have the upper arm straight graft, which is a connection between the brachial artery and basilic vein, and the basilic vein is transposed during this procedure because the basilic vein, of course, is at the posterior part of the upper arm, so the vein needs to be transposed anteriorly to the arm to enable improved access during dialysis. You have the axillary loop graft, or also known as the upper arm loop. This is a connection between the axillary artery and the axillary vein. The thigh graft, which is rarely done, is a connection between the common femoral artery and the common femoral vein, and this is performed on patients who have exhausted all access option in the upper extremity. This is usually not the first choice. Synthetic grafts are usually not the first choice when performing access. and this is because synthetic grafts are more prone to thrombosis and infection, and thus patients are always having to have interventions done to declot the graft or to dilate the graft due to reoccurring stenosis and occlusions. This image here, you have an image of the forearm loop graft, and you can see that this is a graft. You can see the walls are echogenic in this image. The first one, you can see it's a left forearm graft, and the second image that you can see the anastomosis of that graft to the artery. So the first is the anastomosis to the vein, and in the second image you can see the anastomosis of that graft to the artery. Again, that's an image of another forearm loop graft. You can see at the left forearm loop graft here in this patient. You can see that the volume flow here is also 1733. This image was also documented close to the anastomosis there. Turbulent flow as well in the graft. Again, this is because you've connected an artery and a vein using a graft. The four most common dialysis grafts you can see here. Here you can see the forearm straight graft. You can see the forearm loop graft. You can see the upper arm graft also in that image, in the third image, and also in the fourth image of this patient. Excuse me. And you can, and this image, what I love about this image is when you are told a patient has a forearm loop graft or a forearm upper arm loop graft, this helps you to identify location of the graft. And same thing with the prior image I showed with the fistula. The images gives you a picture of what you should be looking for, the location of your grafts, and the anastomosis of these grafts. Common dialysis access complications are: 1, you have thrombosis, 2, infection, 3, stenosis, 4, pseudoaneurysm, 5, Steele syndrome, also known as a distal ischemia, and lastly, hematomas. These are all complications likely to occur from a dialysis access. Here you can see this fistula here. You can see the valve in that image. Looks like a calcified valve, thus causing narrowing in that fistula. So you can see in the first image you have the color image there, and you see the image here in black and white of a calcified valve within the fistula. This is a complication also likely to occur in dialysis fistula. This image here, you see thrombosis at the anastomosis site. If you look at that image here in the first image, right at the arterial anastomosis of this venous fistula, you can see the thrombus, I would say heterogeneous thrombus within that anastomosis site. And during Doppler waveforms of this, velocity was about 875, which is tad bit elevated for velocity flow within an axis. This case study that I have here is a 76-year-old hemodialysis patient, presents with pain in the mid forearm. Patient is 3 months post right radiocephalic AVF. This patient developed pain in the mid forearm. Patient had dialysis a day prior, so patient had dialysis the day before coming for this appointment. and there was a pulsatile mass palpated on physical exam on this patient. So this patient again is 3 months post right radiocephalic arteriovenous fistula. On this patient, imaging showed patent radiocephalic fistula, a 3 centimeter pseudoaneurysm, a 2 millimeter pseudoneck, and patient was later admitted for pseudo repair. So in the next few images here, and you can see in this image here, you can see the large pseudoaneurysm. You can see in that first image the flow into the pseudoaneurysm. The second image here was the measurement of the pseudoaneurysm on this patient with a large pseudoaneurysm in the fistula. Arising from the fistula. And you can see again in this image here, you can see that the opening, the connection there between the fistula and the pseudoaneurysm. You can see the Doppler waveform within the pseudoaneurysm also in this image. Quite an interesting case. Here is an image of a forearm loop graft, venous anastomosis. You can see this image was obtained close to the venous anastomosis. You can see the flow within this graft. This looks normal. You can see the next image there as well. Is a left forearm loop graft close to the arterial anastomosis. These images show a normal velocity within a forearm loop graft. Here is a 77-year-old with upper arm AV graft with chief complaint of tingling and numbness. The first thing is when you have a patient with a graft, you want to rule out a Still syndrome. So study was first performed to rule out Still syndrome. It was negative for Still syndrome. And that's because during graft compression, the radial and ulnar waveforms remain unchanged. And to the right of that image, you can see the waveforms in that radial artery is dampened and not monophasic. PPG waveform also remained the same with graft compression. So imaging was done, and also PPG was done of the fingers with graft compression to see if there was improvement in the waveforms in the radial and ulnar. However, there was no improvement, so that automatically ruled out Still syndrome as a cause of tingling and numbness in the fingers. So upper extremity Doppler was repeated of the native arteries in this patient, and the subclavian, axillary, and proximal to mid-brachial arteries looked normal, was open. However, as you see, there's in this image, the brachial arteries is occluded at the fossa, and there was monophasic Doppler waveforms visualized in the radial and ulnar arteries. So the monophasic and abnormal waveforms visualized in the radial and ulnar arteries is due to this third image here, where there is a total occlusion of the brachial artery at the fossa. So sometimes you have to go a step further when studying patients with dialysis access. Here you have the brachiocephalic fistula, the brachiocephalic with elevated volume flow. Elevated volume flow can also be attributed to large anastomosis site. So you can see in this image here, the volume flow was in the 5,000s. Again, when you look at the anastomosis site in relation to where this image was obtained, it's quite close to the anastomosis site, thus giving you a volume flow of 5,500. And as you go further to the next third image, volume flow was still high, 2331, and this is related to a very large anastomosis site. Alright, we're going to discuss Still syndrome. This is usually seen in the artery distal to the shunt due to low vascular resistance of the fistula. So for example, a patient with a brachiocephalic fistula would likely have a Still syndrome in the forearm of that same arm with the fistula. Patient with Still syndrome will commonly complain of pain, numbness, tingling, and hand coolness. Also, they would also complain of signs includes diminished pulses at the wrist, pallor, and distal ulceration, which could be a finger ulcer or thumb ulceration. Here in this image here, you can see an abnormal waveform in the radial artery, which is distal to the anteriovenous, the AVF, arteriovenous fistula. And looking at this waveform, you can see that this is suggestive of a pre-Still syndrome in this patient. This patient had a brachiocephalic fistula, and this is distal to that fistula. You see this sort of waveform. And in this patient, when the fistula is compressed, waveform would usually go back to a normal radial artery signal.